Now, warfarin is a reasonable anticoagulant to use at HIT, but it must not be started until the patient is stably anticoagulated with a non-heparin anticoagulant. The platelet count is recovered. Warfarin initiates this kind of transient prothrombotic state, which is really the last thing you want to be going on when this patient already has thrombocytopenia and is already showing that they may be forming clots.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your host, Dr. Cyrus Askin.
And I'm Dr. Nick Mark. On this week's episode, we're going to cover a topic that's ubiquitous in the ICU, thrombocytopenia. Specifically, we're going to go on a deep dive into the physiology and pathophysiology of how platelets work, and then using a series of case-based explorations, we're going to talk about specific causes and treatments for thrombocytopenia. Promise it will be a very high-yield episode.
And since neither Nick nor myself is cognitively capable enough to handle this on our own, we went ahead and asked our good friend, Dr. Matt Rendo, to join us. He's sort of become our de facto hematology consultant, I suppose. You guys may remember him from our episode on DVT prophylaxis in the ICU. It's a great episode, tons of useful clinical pearls, highly recommend it. So we are bringing Dr. Rendo back. For those of you that don't remember, Dr. Rendo is a hematology and oncology doc who completed residency in internal medicine at Brooke Army Medical Center in Fort Sam Houston, Texas, and he currently works in Ohio. In Ohio, he sees clinic, he does inpatient hematology and oncology. He's an early career physician researcher. He's published works ranging from the novel uses of cryoprecipitate to describing new treatment modalities for malignancies. He's interested in environmental exposures associated with malignancies and really is a jack of all trades and frankly a master of several as well. So he's a great person to have on the show. We're super excited to bring him back. And of course, as a reminder, if you're interested, you can find him on X or Twitter or Y or Z at RendOncology. So that's going to be RendOncology.
Matt, welcome back to Critical Care Time. How have you been since we last spoke? Any new exciting updates?
Yeah, thanks for having me back, guys. No new exciting updates. Thanks again for that very kind and academic sounding introduction. As you know, I'm a hematologist oncologist, and truthfully, beyond that, I have no real world skills to speak of. One quick update out there, though. There has been a recent change in the world of benign hematology or non-malignant hematology. It's now referred to as classical hematology. And so very excited about that and the opportunity.
And Matt, when we introduce you as a classical hematologist, is there anything you want us to do with the production?
Yeah, let's make sure we're putting in some classical music in there, maybe some Vivaldi. Really zamp that one up when I'm saying classical hematology.
This is like reminding me of like when Michael Scott like walks into business school like with the boombox. Like obviously you need the Brandenburg Concerto when you make an entrance.
Yes.
Also new in the world of medicine are the newly released Figs overalls. I think, Nick, you had shared a photo of that with the group. I bought like several pairs. I can't wait to start using them.
I think this is the intensivist apparel of the season. I don't think anyone can show their face in the ICU without wearing these.
I heard that those Fig overalls have a pocket for the stethoscope. It's actually down there in the middle, so you have to reach down inside to pull out the overalls.
Yeah, and then it's warm.
Patients that there's a pocket in there.
It's preheated.
So the pros and cons are it's warm, improves patient comfort, but they have to watch you remove it, which improves patient discomfort.
Make sure you don't say, "Let me just whip this thing out" when you're blazing saddles.
It's especially awkward if you don't have your stethoscope and you're like, "Oh, can I borrow yours?"
I'll say the other thing is I've often said, how awesome would it be if I could have one outfit, the same outfit, mind you, that I use for rounding in the ICU in the morning, fixing my car midday, and then going fly fishing in the afternoon. Totally good to go, right? Totally good to go. So with that, I think we've probably beaten around the bush long enough. Let's go ahead and, you picked up on that. I like that. Let's go ahead and start this episode in proper with our discussion on thrombocytopenia with Dr. Matt Rendo. All right, Matt. So we really want to start this at the ground floor and then kind of work our way up. So I'm going to ask a very silly, maybe not so silly question. Remind us, what are platelets and why do they matter? Maybe a little bit about where they derive from, and then some of the definitions that we probably need to be facile with before we really embark on this discussion.
Yeah, at the most granular level, thrombocytes or platelets are the sticky components of your blood. They're these small cellular fragments that adhere to the foci and the vasculature when there's been endothelial damage and that underlying basement membrane has been exposed. And they assist in that final step of the coagulation cascade as well, sticking together, forming a blood clot, allowing a clot to form at a foci where there's been damage that is occurring. When you're shaving and you nick yourself a little bit on the face, there's platelets that are flooding to that foci, stopping that little venule or that vascular location where there's been damage to stop bleeding secondary to a clot being formed. They're produced inside of the bone marrow, and they're derived from megakaryocytes, which are the largest cells in the bone marrow, and they're responsible for packaging organelles and the granules within the platelets prior to them blebbing off and then circulating in the peripheral blood as well as within the spleen as well.
And I know this is going to come up, Matt, but the signal for the production of those megakaryocytes and then subsequently platelets, where's that signal come from?
So that signal's coming from the liver. That's a signal. It's called thrombopoietin or TPO. It's an analogous to EPO or erythropoietin, which comes from the kidneys to stimulate red blood cell production within the bone marrow.
Perfect. Okay, I think that's going to be relevant later on, so I wanted to make sure we got that out of the way early. And I had asked also about definition. So Matt, is there a kind of accepted set of definitions that we use to talk about things like mild or moderate thrombocytopenia?
Yeah, in terms of mild thrombocytopenia, and the first place you're looking at the cutoff is when those platelets are dipping below 150. So a mild thrombocytopenia is 150 to 100. A moderate thrombocytopenia would be 100 to 50. And then a severe thrombocytopenia categorically would be any platelet count less than 50. Now, this is also dependent upon what the underlying disease state is, and it may change the interpretation of that thrombocytopenia. For example, in the setting of ITP, immune thrombocytopenia, we don't categorize it as a severe thrombocytopenia until that platelet count dips below 30.
Awesome.
Got it. And I think maybe one other point we should make for our listeners is that the risk of bleeding, that's why we care about platelets, isn't linear with the number of platelets. It's not like if my platelets are 300 and then they fall to 200, my risk goes up, right? Like how does risk change?
So the risk for spontaneous bleeding really doesn't start to come into play until, number one, patients are critically ill and their platelet counts are starting to dip below 30, or the platelet counts are starting to dip below 10. There's a lot of literature out there that indicates there may be elevated risk for spontaneous bleeding going on when platelets are dipping below 10, whether that's secondary to mucosal surfaces being manipulated in the mouth and bleeding, whether that's due to, somebody has a mild trauma or sneezes and they tear bridging veins within their head and has, higher risk for intracranial bleeds. But that significant increase really doesn't start to play until we get below 10. So to go back to your point, Nick, going from 300 to 200 down to 100, you're not significantly increasing your risk for bleeding.
Great, Matt. So now that we understand why platelets are so important, let's start by building a framework. And listeners of our show, remember that in the hyponatremia episode, we said that one of the first steps you ask when you see a low sodium is this even real? Matt, is there a corollary with hematology that we ask? Is there like fake thrombocytopenia we need to be worried about?
Yes, absolutely. And the one that's common is known as pseudothrombocytopenia. And essentially, there's two types. The first one is a sampling error. There's been some incompletely mixed or inadequately anticoagulated sample that's been obtained from the patient that's resulted in a clot that traps those platelets in the collection tube and prevents them from being counted. The other one, the one that we typically think about, is platelet clumping. You look at the smear and you see clumping going on of those platelets together, or they rosette around white blood cells. That's seen in anywhere from about 1 to 500 up to 1 in 1,000 patients. And it's secondary to the EDTA anticoagulant that's within the collection tube, inducing these platelets to clump, or like I said, rosette around these white blood cells themselves. Importantly, if platelet clumping is observed or platelet rosetting around white blood cells is observed, the platelet count needs to be repeated using a collection tube containing heparin or sodium citrate as the anticoagulant and not EDTA. That's one of the more simple things you can do up front, especially in the setting of a patient that's ambulatory, not critically ill, has no abnormalities in their hemoglobin or their white blood cells as well.
And to clarify, that's a blue top tube, is that right? Like normally
Correct.
you draw it purple, and this time it's going to be blue for citrate.
Yep.
We like colors on this show.
Very basic people.
Okay, so now that we've established that a low platelet count is real, maybe we should talk a little bit about how platelet count differs from coags and how those two kind of separate but connected systems work together.
Yeah, no, absolutely. Definitely separate, but also at the same time, heavily dependent upon one another. In order to function appropriately, platelets have to have normal amounts of coagulation factors, specifically the last step in the coagulation cascade. Factor 1, also known as fibrinogen, has to be at an adequate level in order for a platelet plug to actually form in and of itself. Just because a patient has low platelets doesn't mean they're at a significantly elevated risk of bleeding. They could have normal platelets. They could have platelets in the low 100s, even higher. But if their coagulation factors are significantly compromised, for example, in the setting of severe cirrhosis, decreased synthetic liver function, maybe severe malnutrition with a vitamin K deficiency, which is vitamin K is necessary for factors 2, 7, 9, and 10 synthesis in the liver. If you have those types of deficiencies, you can also be at a high risk for bleeding. Coincidentally, on the other side of that spectrum, you can have normal and appropriate coagulation factors, but if your platelet counts are really low, say you're floating around severe ITP and your platelet counts are below 10, you can have a high risk for bleeding in that space as well.
Got it. So both important. You can bleed with deficiencies of either, but in many cases, you end up with deficiencies of both because there are situations that will deplete both your platelets and your clotting factors. For example, we'll talk about liver disease.
Correct.
Now, I know you want to get to the schema because that's going to give our listeners an understanding as to how to kind of classify these disorders and work them up. But I did have a quick question. We were talking about the interplay between platelet counts and the coagulation cascade and the fact that they're obviously separate but related. In the ICU, I don't know if I'm too big of a fan of this, but a lot of times when I have some of these more complex patients, particularly those with liver disease, I actually like thromboelastography to try to get a feel for what's actually going on in a more granular sense than your typical coagulation assay. I may use it maybe more than the hematology guidelines might suggest. I'm not sure. Matt, do you have any kind of experience with TAG or thromboelastography as it relates to the use in the intensive care unit? I know in trauma it's got a pretty decent place, and there's somewhat of a literature base there. But outside of that, any experience there?
No, not really robust. The things I know about TEG in the setting of thrombocytopenia and specifically with liver abnormalities, I know that it was used initially on with like orthotopic liver transplants, and really trying to determine whether or not they needed to give platelets versus cryo or other coagulation factors. But I don't have a really large robust experience with it. I know that especially in the setting of COVID when patients were having, diffuse kind of intravascular coagulation. A lot of times they were using it when these patients had severe thrombocytopenia as well. But no, I don't have extensive background in it by any means.
Yeah, Nick, I don't know what your experience is. I've personally, I like it because if you get that assay, it generates for those that aren't as familiar, it generates this graph. It kind of looks like a wine glass on its side, and not only can you assess for some of the potential coagulation deficiencies that could be remedied by things like FFP or cryoprecipitate, but you actually do get that maximal amplitude as well that's generated, which kind of can tell you if the platelet count is sufficient to generate enough of a clot versus if maybe the platelet count is not sufficient in that particular patient to generate the kind of clot that you need. So that's kind of why I like it. I don't know, Nick, what's your experience?
Yeah, no, I'm a big fan of TAG. I think TAG or ROTEM are both really good techniques. I think, if you'd asked 10 years ago, I think the data was less mature. And now I think there's more data to suggest in liver transplant, it reduces transfusions, but equivalent outcomes. There's an emerging literature in like cardiac surgery and medical patients. So I think, we'll obviously have to have a future episode just about TEG because I think it's an exciting topic. But personally, what I like about it is that it gives you sort of a 30,000-foot view of both platelet function and coagulation. And you can see not just the platelet count, but the max amplitude gives you a hint about how well the platelets are working. So for example, in somebody who's like uremic, they might have a normal platelet count, but their platelets are not doing their job very well. So I think it's a good technique, but I think it's funny. I think the hematologists tend to look at it and say, but it doesn't tell me what's wrong. Like you guys have more specific tests to zero in on the problem. And this is kind of useless because you're like, well, I'm going to find out what the functional platelet issue is. I think for us, sort of middle of the night, very useful for sort of characterizing which thing do I need to transfuse into this person.
Yeah, that's totally how I use it. And just the last thing I'll say on this, because I know we have a lot to get to, is it's not hard to envision the patient with cirrhosis who's also uremic, who therefore has a low platelet count, and they have an INR that you can't make any sense of. And so in that setting, I just find your traditional coagulation assay to be not that helpful. And I don't know if is this person with 68 platelets, is that what's driving it? Is it the coagulopathy? What is it? And so I find that thromboelastography is just a nice little tool in the toolbox to use in addition to all your other clinical tools. But that's how I approach it.
Okay, yeah, great point. Listeners, stay tuned. Future episode on TEG coming at some point. Now back to thrombocytopenia. So Matt, you've given us this great kind of overview of why we should care about platelets, how we should measure platelets. Can you give us the 30,000-foot view of just what causes low platelets? Give us a couple big boxes we can sort things into.
Yeah, absolutely. The three camps I categorize them into when I'm thinking about thrombocytopenia is there increased destruction, is there decreased production, or is there sequestration? Looking at increased destruction, there's really kind of two sub-flavors of that. Is there an immunologic cause for why there's increased destruction? Is this some type of ITP? Is there an antibody being directed against the platelet? Alternatively, is there an antibody being directed against TPO or antibodies being directed against the megakaryocytes, a phenomenon known as a megakaryocytic thrombocytopenia? Alternatively, there's non-immune etiologies for why patients have increased destruction of the platelets. Commonly, this is due to thrombotic destruction resulting secondary to diffuse endovascular damage, whether that's DIC or things like thrombotic microangiopathies.
I would add to this list of non-immune, it's often our fault. Especially as an intensivist who works in a cardiac ICU, we're often putting in devices. We often have narrow valves that need to be replaced. And so this is a frequent category where, an Impella or a balloon pump or something is just chewing up platelets.
Yeah, and I'll say the one thing that I find helpful, like with the Impella, for example, is one hint of that is if you see the urine go from clear yellow to red, it's okay, well, you might be causing some hemolysis, and oh, by the way, that may be contributing to some thrombocytopenia too. So great point, Nick.
And that's actually an important thing as well. We're talking about the interplay between these coagulation factors and platelets. Things like Impellas or some of these vascular devices, specifically Impella, these patients can get an acquired von Willebrand deficiency due to that Impella churning up that blood and lysing some of those proteins, those big large multimers as they're coming down the pipe. And so again, going back to that interplay between protein coagulation and platelets, they might have normal platelet counts, but their Impella may be chewing up their von Willebrand factors, leading to a coagulopathy.
That's a great point. Okay, so we talked about increased destruction. We broke that into immune and non-immune. Let's talk now about the next big category, decreased production.
Yeah, and the production factory for platelets is within the bone marrow. Going back, they're produced by megakaryocytes. Megakaryocytes are stimulated by thrombopoietin, which is generated from the liver itself. And so the production of those platelets is really dependent upon an intact hematopoietic stem cell and megakaryocytic function within that bone marrow. And there's plenty of things out there that can suppress that and decrease the efficacy and the efficiency of producing those platelets, whether it's due to toxins that are being consumed. Most common cause out there is alcohol. Whether it's due to infiltration, crowding out those megakaryocytes from being produced and generating platelets, whether that's secondary to things like fibrosis, myelodysplastic syndrome, metastatic lesions to the bone marrow themselves, things like leukemic blasts that are taking up space, or nutritional causes, patients that have severe vitamin deficiencies, folate, B12, copper, zinc deficiencies, primary bone marrow failure disorders, or primary platelet dysfunction syndromes, rare things like Bernard-Soulier, great platelet syndrome. Those can all lead to decreased production. But again, it's not just the factory itself, it's also the fuel that's going into the factory. So hitting back on that TPO that's produced by the liver, anything that's driving down the efficiency of the liver from producing TPO, again, whether it's toxins that are being consumed, alcohol, again, being the most common cause. And then a lot of patients with cirrhosis have decreased synthetic liver function, decreased TPO production. All of those can lead to decreased production of platelets at the end of the day.
And it's not uncommon to encounter someone with a history of cirrhosis who's also still actively consuming alcohol. So there you go. I mean, that's a double hit right there.
Yeah, and then those cirrhotics, I know we'll talk about this later. There's estimates that like 50% of patients with Hep C cirrhosis have thrombocytopenia already. So I mean, it's not insignificant how many patients with cirrhosis out there already have thrombocytopenia.
Okay, and then on to the last category. So you mentioned increased destruction, decreased production, and then last category, sequestration. So what falls in there?
So sequestration is primarily sequestration of platelets, commonly within the spleen. The most common cause for why patients are having sequestration within the spleen is secondary to portal hypertension. One of the most common causes for why patients are having portal hypertension, cirrhosis. So a lot of those same etiologies that are driving cirrhosis, driving portal hypertension, you're not only getting you're getting a 2-for-1. You're also getting decreased TPO production, but you're also getting those platelets being sequestered and pushed downstream due to that higher kind of resistance within the portal venous system. And those platelets sometimes get sequestered within the spleen itself. Other kind of rare or uncommon etiologies that can lead to splenomegaly, some other types of infiltrative diseases, again, whether that's going back to things like polycythemia vera, central thrombocythemia. Sometimes the spleen can be a secondary source for hematopoietic production. If the patient has severe bone marrow fibrosis, and their hematopoietic system is set up shop within the spleen, that can also lead to splenomegaly and subsequently splenic sequestration of platelets.
Excellent. So sort of to just kind of quickly recap that, we talk about increases in destruction of platelets, which can be immune modulated or not immune modulated. We talk about decreased production. We talk about sequestration, and those are really all things we should sort of all of those general etiologies are things we should be familiar with, certainly in the critically ill, but really in any patient, it sounds like, Matt.
Absolutely.
Kind of going from there, I assume that the treatment for all of these cases is simply we give platelets whenever we kind of feel like it, and that's that. Am I oversimplifying
Transfused
it or
to 300, right?
Yeah,
Just back to normal.
Yeah.
Yeah, don't tell that to any of the classical hematologists out there. They're not going to respond well to that feedback.
So what should we do, Matt?
So a general rule of thumb is that if these platelets are below 10, you're going to transfuse them kind of regardless of the situation. If the patient is fevering and their platelets are below 20, there's thought that there can be increased consumption of platelets, and so transfuse them at 20. If a patient is bleeding below 50, transfuse them. And then there's a whole myriad of different types of procedures that indicate when a patient is and isn't going to need a transfusion. But if they're going to have something like a central nervous system surgery, or certainly if they're having some type of open heart surgery, oftentimes they're transfusing with a platelet count of 100.
And looking over these guidelines in preparing for this episode, I saw a lot of weak recommendation based on very low quality evidence. So, I think we can talk more about the specifics of this, but there's surprisingly little evidence for higher transfusion thresholds. That depending on where you are, like the American Society of Hematology versus the British Society, different thresholds. So once again, we're in a situation where depending on which side of the Atlantic you're on, the treatment is different, apparently.
Yeah, I agree, Nick. A lot of these are based off of, like you said, they're very low grade recommendations. Sometimes you'll see, evidence-based recommendations that, a grade B or grade C. A lot of them have just become kind of standardized and ingrained in like you said, American hospital culture. These are what we do. These are what we've been doing. Is that just part of the, the ignorome that we all kind of feed to each other? Or is that definitive? Yeah. Oh yeah. If you're below 10, you're definitely going to bleed. Well, maybe not. I've seen patients walking around, coming into the ER with platelet count of, 6 or 5 with an AML. They've maybe been sitting there for the last couple of, days to weeks. Or is it something where it's like, hey, it's 5? We just don't have a lot of that standardized data because it's probably hard to get through an IRB and say, hey, I don't want to transfuse this guy until his platelets are like 1 or 2,
Right, right. Yeah, I think I really like your framework of 10, 20, 50, 100 as sort of the big cutoffs. I think that makes a lot of sense. It's easy to internalize, and you may have to customize a little bit. There may be somebody with lower values who isn't bleeding. There may be somebody who's bleeding despite higher values. I mean,
Absolutely.
obviously, if somebody's platelets are 11, it doesn't mean they should go like lie down on a bed of nails or something for fun. But it's good to sort of put the number in the context of the patient. Maybe another thing we should talk about is when is transfusing platelets not a good idea?
Great question. The time to hold off on transfusing the patient platelets, number one, if they're not meeting those criteria we just discussed, but also give pause and give consideration to the setting of immune-mediated thrombocytopenia. The treatment should be derived at mitigating the underlying cause that's deriving or causing that thrombocytopenia, that's spitting out that antibody, that's either clearing those platelets, clearing the TPO, or something along those lines. You're not fixing the underlying course. You're trying to slap a Band-Aid on it, but you transfuse platelets into somebody that's already got an antibody waiting in there, and it's like fish going into a net right away. They're going to be caught and removed in the spleen by macrophages and other components of the immune system immediately. So some of those immune-mediated things like ITP, rare but not unheard of in the previously pregnant female who's had a recent transfusion, and they've developed an acute drop in their platelets, oftentimes below 20. They'll also commonly have purpura, a phenomenon that's called post-transfusion purpura. This is a delayed transfusion reaction in which the patient developed antibodies that destroy the recipient's its own platelets. In that setting, you need to be very cautious and make sure you're working close with the blood bank to ensure the patient is receiving platelets without some of those target epitopes on them. Also, immune-mediated phenomena that's called platelet refractoriness. This is in patients with a heavy transfusion history. Some of these guys walking around with MDS that are getting blood transfusions or platelets every couple of weeks. Maybe somebody that's been in the hospital for several weeks with AML and they've got multiple transfusions. They've developed anti-human leukocyte antibodies, HLA antibodies, or anti-human platelet antigen antibodies. This is seen when you transfuse somebody, you come back the next day, recheck that CBC, and the platelet count hasn't moved. It's maybe even come down. And the way to figure out if there is platelet refractoriness, the first thing you're doing is transfuse them with platelets, and then 1 hour later, check it again. If there's minimal response, that's going to clue you into, hey, there's probably some type of antibody here floating around that's potentially cleaving them. Other things to make sure you're doing as well. If they're bleeding and their platelets are low, make sure they're not in DIC. Replace that fibrinogen. Make sure you're checking those other coagulation factors that could be potentially causing them to bleed, and that's the source for why their platelets are actually low, not some immune-mediated phenomena that's going on. Or make sure they're not, in Florida, like I said, Florida DIC, make sure they don't have acute AML. Again, this is something where you're going to be working in close conjunction with a blood bank if you are concerned that there is platelet refractoriness, making sure that those patients are receiving the appropriate blood product.
So I think my big takeaway is to be thoughtful and not purely reflexive in ordering transfusions. And when somebody isn't bumping appropriately, this is a situation where you need to think about why instead of just pouring unit after unit in.
Yep. Make sure you're not missing a bleeder somewhere. Make sure that those coagulation factors are appropriately replaced, especially fibrinogen. Fibrinogen is the first factor that's going to deplete. And that's the last link in those platelets in the coagulation cascade that are allowing those platelets to stick together and form that clot. And so if your fibrinogen is very low and those patients are oozing from mucosal surfaces, it may not matter how many units of platelets you're dumping into them if they're continuing to ooze out.
Awesome, Matt. So I think that pretty much sums up the first half of this discussion where we really kind of reminded our audience, okay, what are platelets? What do they do? They're tremendously important to stop bleeding. They're sort of the agent of the coagulation cascade in the sense that you need platelets to kind of start things off. You need the coagulation cascade to ultimately stop the bleeding. But without platelets, you're not going to be successful in that regard. We talked about some definitions, specifically, what mild, what moderate, what severe thrombocytopenia are, and how that's a little bit nuanced depending on the underlying disease. And then we sort of continued on and talked about how it's not necessarily a linear process. So you can have 300 platelets or 200 platelets, and the likelihood that you bleed may be statistically the same. Whereas you could certainly have someone at 100 and then someone at 20, and there may be a very big difference there in terms of how likely they are to bleed. So it's not just the number; it's taking a lot of different things into account, and it's not simply a linear relationship. And then briefly, I know, we did talk about a lot here, but we talked about a general framework for thrombocytopenia and how we look at it is in terms of, destruction versus production versus sequestration. So certainly, I think there's some great pearls there. And then finally, we talked about treatment there. So based on what you said, Matt, there are certainly times when giving platelets is appropriate, but giving platelets for every case of thrombocytopenia is certainly not the right answer. And so first you want to make sure you've confirmed the thrombocytopenia. You want to make sure that we're not dealing with clumping. I think that's a big issue there, or a sample error. And once you do, it's like, okay, is this thrombocytopenia because someone's bleeding and their fibrinogen's in the toilet? So you're going to give them cryo, you're going to give them platelets, you're going to give them blood, or all those fun products. Or is this an ITP type situation where it's antibody mediated and giving them platelets is just going to add fuel to the fire? So I think that's pretty much my summary. Any big lapses in understanding there, Matt?
No, I think you hit the head on the nail on the head there. The only thing I think I would harp on again is really that kind of that interplay between the coagulation factors and the platelets. It's bricks and mortar. Bricks being the platelets, mortar being the coagulation factors. You can't build a stable clot of a wall without mortar between them, and you got to make sure they really have both components in order to make a firm platelet plug.
A wall without mortar is not a wall without bricks. Just mortar is not going to stand very long.
Yeah, it's just slop.
Right. Well, on that note, I think that was a great kind of introduction to platelets, and now I think would be a great time to move into some cases where you can discuss this in some clinical context. Okay, so Matt, in keeping with the construction allusions, the construction analogies, I think we've got this great foundation, and we're gonna build on that foundation by going through some cases. And so I'd like to start off with one that we, Nick and I, we see this in the ICU probably every time we walk in. Let's go with a 45-year-old male, let's say. History of sepsis due to multifocal pneumonia. He's on multiple vasopressors. He's got a history of atrial fibrillation. He's been stable on apixaban without any issues. And the ICU team decides to continue it during his hospitalization because he doesn't have any kind of active bleeding issues or what have you. During the course of his hospitalization, it's noted that his platelet count kind of steadily decreases, particularly in the first few days. And the team is wondering, okay, what's going on? And they do their workup. There's no bleeding. He's got his FAST is negative. They send him for a CT. CT's reassuring. So what do we think might be going on in a situation like this, Matt?
Well, that's a great question. Like you said, this is a common consult we get as well from thrombocytopenia in the setting of some type of infection, florid sepsis that's going on. And there's literature out there to indicate that there's direct bone marrow suppression in the setting of this septic physiology, whether that's directly due to cytokines that are released from the patient's own immune system, or that's due to some type of inflammatory mediator or endotoxin that's released from bacterial sources they're floating around in the bloodstream. But oftentimes in that same vein, as the endotoxin is released, it's often resulting in DIC. So you're getting not only bone marrow suppression, but also consumption of platelets in the setting of these microthrombi that are being formed throughout the vasculature. But it's not just bacterial causes; it's also viral causes as well. Measles, mumps, rubella, COVID, other viral infections oftentimes can result in a suppression in the synthetic bone marrow function. Generally, as those viruses are running their course, it seems like they tend to have an improvement. But again, if there is severe liver disease or liver damage that's occurring second to those viral infections, it may not just be some type of suppression on the bone marrow. It may be, again, going back to that TPO that's being produced from the liver that's being decreased in that setting.
Awesome. That's a great explanation, Matt, of something that we see not infrequently. So just a couple kind of follow-up questions would be, one, how do we actually diagnose this? It sounds like it's sort of a diagnosis of exclusion. And then number two would be, how common is this? How high should it be on our differential for a patient like this?
Yeah, and just like you said, it seems like it's relatively common, or at least a consult that we get for ICU. There's a systemic review out of 2011 that, a very broad percentage, but they indicated anywhere from 8 to 68% of ICU admissions have some type of new onset thrombocytopenia during the ICU stay. I've seen other literature, reporting anywhere from 13 to 44% as well. But going back to your question of how do we diagnose it, usually you're finding that culprit infection during that infectious workup. Oftentimes within the setting of DIC for a patient that has sepsis. So you're looking at their coags and their coags are out, maybe their fibrinogen is low as well. That'll start to give you a little bit of clue. And you generally start to see an improvement in those counts as that infection starts to resolve, and they're starting to improve from that standpoint.
Awesome. And I think from what I've seen, this person obviously has some risk factors for bleeding as well. They are on an anticoagulant. Sometimes in the setting of sepsis, if you have an anticoagulant that's cleared by the kidneys, you've got renal disease, you could have increases in serum levels. And so I think it's important, to make sure that what I always teach my residents is if the patient has a drop in their platelet count, especially if that's associated with a drop in their red blood cell count, it's bleeding until proven otherwise. And to me, you need to rule that out first. And then once you do, you can move on to other things. And we'll send off our assays and whatnot. And then we'll sort of turn to sepsis as being the culprit. But I think it's really important for those, especially early career physicians or even, nurses that are on the medical team that may be helping with patient care. It's like, okay, well, let's make sure they're not bleeding first. And then we can start to look at other things. What do you think about that, Nick?
Yeah, I agree. And I think one other quick point I'll make just about common things being common. Maybe I'll phrase this in the form of a question. So Matt, what if you got this consult, but the patient was on both linezolid and Bactrim for some reason? What else common things?
Yeah, that's definitely ruling up the concern for maybe a drug-induced thrombocytopenia, or at least a concurrent or compounding what's going on in the setting of this thrombocytopenia. And that's very important, Nick. You need to make sure you're looking at those antibiotics the patients are on to see if they are potentially offending agents causing that thrombocytopenia. Like you said, Bactrim, sulfonamides are notorious for causing this. Linezolid as well. Vancomycin, we've seen that time and time again. Making sure you're looking at taking a quick look at the medications that the patient is on and seeing if any of those are responsible for drug-induced thrombocytopenia. And the list for drug-induced thrombocytopenia is pretty robust. You do a quick lit review and you'll see anywhere from 40 to 60 different medications that have been associated with thrombocytopenia. So make sure you're doing the patient due diligence, not just chalking up merely to some type of, septic physiology, but making sure that there's no iatrogenesis involved in there that's driving down those platelet counts.
I think that's a great summary, and it's a great plug for why having a clinical pharmacist with you on rounds who can, be thinking about the timing of the drop, and especially as that relates to when medications were added, can be super useful. Okay, so case number 1, sepsis-induced thrombocytopenia, common things being common. Let's move on to case number 2. So this is a 54-year-old man with a history of pulmonary embolism. He is deemed to be intermediate risk, so he gets a pulmonary consult. He feels pretty well, other than the reason why this all happened. He fell off a roof, he broke his femur a few weeks ago, and that's why he was immobile, which is presumably why he developed a DVT and then a PE. Anyway, he's in the hospital, he's on a heparin drip, and for various reasons, he's on that drip for about 72 hours, and then they notice that his platelet count has dropped from 300 to 100. And then the astute medicine intern goes to the bedside and notes that he's got this newly swollen right calf. They do an ultrasound, they see that he's got a DVT, a new DVT, in his right common femoral vein. So just to put all these pieces together in my rambling case here, he's gotten heparin, he's thrombocytopenic, and now he has a new thrombus. What are we worried about here?
Yeah, the alarm bell should be going off that this has maybe hit heparin-induced thrombocytopenia. And the space in which that should be something you're concerned about is there's a new onset thrombocytopenia. Your platelet counts have decreased, usually by 50%. Important point to drive home here as well. Even if the platelet count exceeds, 150, those platelets dropping anywhere from 400 to 200, that could be, something that's concerning for HIT.
So even if it's not red yet, it's still bad.
Exactly. The patient has new clots. There's skin changes, like they have necrosis at the injection site for their heparin. Or they have any other type of, acute systemic illnesses, fevers, chills, tachycardia, hypotension, cardiopulmonary arrest occurring after they've received their heparin. I think we would be remiss if we didn't touch on the pathophysiology of this before going any forward. There's an antibody in HIT that's directed against an endogenous platelet factor 4 complex. Now, platelet factor 4 binds to heparin and decreases its ability to anticoagulate. This, in turn, activates platelets, causing arterial thrombosis, causing venous thrombosis after heparin exposure. And it's certainly not something to sleep on if you have a concern that there is HIT occurring, because the untreated mortality with it is above 20%.
And just to sort of like emphasize that point there, so normally we are using heparin to quote thin the blood, but in HIT, what's happening is actually the opposite, right? That your heparin is getting all bound up on platelets and it's activating those platelets, so it's actually a procoagulant state. And so,
Exactly.
yeah, as you said, I mean, heparin exposure is the key risk factor, and a failure to recognize it is, potentially catastrophic with like very high mortality. I often tell people, convince me why this isn't HIT. Like, turn it around. Like when you see a drop in platelets, I want to reassure myself first. So, when you're trying to convince yourself that somebody doesn't have HIT, is there any way that we can risk stratify them?
Yes, it is through calculating a 4T score. So the things that a 4T score takes into account is if the platelet has fallen by greater than 50% and the nadir count is above 20. Important with HIT, unlikely are you going to see a nadir for the platelets below 20. If those platelets fall within 5 to 10 days after heparin was initially given, or they fall 1 day with a prior heparin exposure less than 30 days previously. If the patient has new thrombosis or new skin necrosis, specifically in the region where heparin was being administered. And they can get other points as well if there's no other apparent cause for why the patient has thrombosis. Alternatively, they get no points if there is a definite cause for why there may be other causes of thrombosis. A score of 4 to 5 is an intermediate, and greater than 6 is likely HIT. In the setting of intermediate, it's advised to stop giving that patient heparin and start a workup, looking into seeing if this patient does indeed have HIT. The first step in doing that workup is completing an ELISA that detects antibodies against platelet factor 4 heparin. However, this just detects an antibody floating around the serum. It doesn't actually determine if that antibody is responsible for activating those platelets. And so if there's an intermediate result on that ELISA, the next step is to order a functional platelet assay to confirm. The one that's most commonly used here is serotonin release assay. And what it does is it assists in the detection of those antibodies that can actually induce heparin-dependent platelet activation.
And just as a quick aside here, I mean, I see a lot of patients in the post-cardiac surgery setting, people who have received massive doses of heparin. And so just my personal practice is that I don't ever send the heparin PF4 antibody alone. I always send both, because the likelihood of having an indeterminate result on one is so high, and the serotonin release assay for my shop at least is a send out. So in order to save time, I often send both. I think the guidelines recommend doing it in sort of a staged workup, but I think, this is a situation where you got to think about what your pre-test likelihood is.
No, I think that's a great point, Nick. The ASH guidelines do say do the ELISA first, followed by the functional platelet assay second. But if it's going to take 2 to 3 weeks to get that serotonin release assay back, and you don't have time to make that type of a decision, maybe that patient's going to be, switching to an oral anticoagulation from some type of parenteral in the meantime. I think you do what's right for the patient, and I think that your schema that you're following is oftentimes what is right and best for the patient.
All right, so obviously, Matt, you said we've got some tests that we need to order. Some of them are going to come back quicker than others. All that being said, if we're really concerned, if we have a high enough 4T score and we want to do the right thing for this patient, what are we going to do up front in regards to their heparin and their needs for anticoagulation? And then what are we going to be thinking about doing down the road? Anything we need to be keeping in the back of our minds?
Yeah, absolutely. So the first step is stop that heparin. That's the offending agents that's driving that HIT. If that patient is on warfarin, you're going to hold it, reverse it, give them some vitamin K, and then use a non-heparin anticoagulant. Like you said, you've already ordered that HIT testing, the ELISA, or the serotonin release assay. ASH guidelines also advise to get an ultrasound, bilateral lower extremities, and if there is any type of vascular instrumentation in the upper extremities, making sure we're getting an ultrasound of the upper extremities as well. There's a couple different non-heparin anticoagulants that we can reach for. In the parenteral setting, you're looking at argatroban, bivalirudin, fondaparinux. Direct oral anticoagulants, you're looking at things like apixaban, rivaroxaban, edoxaban, and then alternatively dabigatran as well. Um, Going back to talking about holding or reversing warfarin. Now, warfarin is a reasonable anticoagulant to use at HIT, but it must not be started until the patient is stably anticoagulated with a non-heparin anticoagulant. The platelet count is recovered. And it's very important to remember that warfarin initiates this kind of transient prothrombotic state, which is really the last thing you want to be going on when this patient already has thrombocytopenia and is already showing that they may be forming clots. But there's a little bit nuance in there that we need to unpack a little bit more in determining what's the optimal anticoagulant you want to use in that patient. For example, patient's critically ill, they have maybe a very high bleeding risk, maybe they need some type of procedure that's going to occur. Argatroban or bivalirudin are going to be given their shorter duration of effect, fast time on to fast time off. If the patient's stable, fondaparinux or one of our direct oral anticoagulants may be preferred due to the ease of administration, lack of need for lab monitoring, and feasibility for outpatient use.
Okay, so that's a great summary, and I think just to break it down a little bit. So in the critically ill patients, we're going to use bivalirudin or argatroban because you can turn them off quick if there's bleeding, and in the stable patients, we can use an oral agent like a DOAC or fondaparinux. Now, one question that's kind of driving me a little bit insane is we're avoiding heparins, no unfractionated heparin, no low molecular weight heparin. Why are we still using fondaparinux? Isn't that a heparin?
Nick, I had the same question. I've never really understood this.
No, that's a great question. Unlike heparin, fondaparinux does not bind to platelet factor 4, so it's not involved in that same type of complex and antibody formation.
Got it. Okay, so it's doing all of the anticoagulation things, but it's not doing this off-target heparin PF4 thing. So fondaparinux, okay. That's a great point.
So, so kind of continuing on with our discussion. So, kind of long term, what are we doing with these folks? Like, how long do we have to anticoagulate them? And then, I guess we'll take a step back too and say, let's say that your assay comes back and it's clearly not hit. What else should be or would be on your differential, Matt?
No, that's a great question. First of all, let's tackle the anticoagulation. If this patient does not have any type of thrombosis that's been identified, say on lower extremity ultrasound, bilateral upper extremity ultrasound as well, but they have definitive hit, their platelet counts dropped very quickly, greater than 50%. They had a 5, 6, 7 on their 4T score. What's the duration of your anticoagulation? For no thrombosis, no blood clots, you're looking at 4 weeks. If there is a blood clot, you're looking at least 3 months in that setting.
And that person's never going to get heparin again. Is that correct?
Yeah, I wouldn't mess around with heparin in that patient ever again.
Perfect. So add it to their allergy list. The reason is HIT.
Yes.
Yeah, to avoid that, because somebody will inadvertently give it to them as prophylaxis if they go to the hospital.
And then God forbid the next time that guy comes in and he's got pneumonia, and then he gets some DVT prophy, and then he gets big DVT and a massive PE, right? So I think it's not safe for that patient to receive heparin anymore. Just like you said, Nick, make sure it's going on their allergy list.
Yeah, this is a good example of something where if we think short term, we could save this person's life, but if we don't think long term, somebody who's in the medical system is going to be exposed again unless we go out of our way to protect them.
Awesome.
Yep. And then to answer your second question there, Cyrus, what else is on your differential? And that's very important to drive through when you're going through this workup for HIT. Again, making sure you're not just giving this patient long-term anticoagulation with the risks associated with that. And the things that are common are, especially in the ICU where you're seeing these patients, do they have DIC? Well, unlike HIT, DIC, their coag is going to be out, their fibrinogen is going to be low. HIT is associated with clotting, as you can also see in DIC, but DIC also typically see oozing as well. Is there thrombocytopenia being driven not just by HIT, but maybe there's some type of sepsis or infection, just like we talked about earlier with the bone marrow suppression? Typically, in the setting of that, you're also seeing a decline in your hemoglobin, sometimes in your platelets as well. Does this patient have ITP, immune thrombocytopenia? Well, ITP doesn't have any association with heparin, nor does it cause patients to clot. It just drives down their platelet count. Alternatively, is this a drug-induced ITP? Like we talked about earlier, some of those antibiotics, the linezolid, the sulfonamides, vancomycin, common things that they can be on, like NSAIDs and Tylenol, can be associated with inducing a drug-induced ITP. Going back to that post-transfusion purpura with a patient that's got prior pregnancy, maybe a recent transfusion, maybe not clots, but they may have skin necrosis. However, divergent with HIT, in the setting of PTP, those platelets are usually dipping below 20. With HIT, the platelets are usually maintaining above 20. Further down on our differential, are thrombotic microangiopathies, things like TTP, thrombotic thrombocytopenic purpura, HUS, drug-induced TMAs. Both thrombocytopenic, both of them can clot. However, when you look at the smear, you're going to see schistocytes evident in the setting of a patient that having a TMA. And then something else that's very common as well, does this patient just have a venous thromboembolism secondary to being sick and in the hospital? Like we've talked about before, one of the most common cause of undiagnosed or at the time of death, undetermined death is due to VTE. The patient may have received heparin, but again, being in the hospital, being critically ill, being immobile, in that hospital setting, they're already at risk for having thrombocytopenia. They're also at risk for having venous thromboembolic events. So was it just an unfortunate combination of both of those? Alternatively, one of the things you need to make sure you're thinking about and doing a deep dive into their history, making sure they don't have any type of rheumatologic history, lupus. When you see mild thrombocytopenia, you see venous and arterial clots. Is this some type of antiphospholipid antibody syndrome or catastrophic antiphospholipid antibody syndrome, where they can get skin necrosis, they can get necrosis of limbs and fingers, and they can get venous and arterial clots. The difference between HIT and that is that in the setting of antiphospholipid antibody syndrome, they're going to have specific antiphospholipid antibody syndromes. They're not going to have antibodies directed at platelet factor 4. Important thing about that, though, if you ever have a patient with antiphospholipid antibody syndrome, the only anticoagulant that's safe for them to use is warfarin. It's been compared against DOACs before and head-to-head with increased risks of clots in the setting of DOACs compared to warfarin. Just a little bit of an aside.
And Matt, I think to round this up, well, first of all, that was a great differential, and hopefully our listeners appreciate that.
That was a hematology fellowship right there, I think.
Yeah, I think so. Now to round things out, I think it's probably important to discuss how common is this. My recollection is it's surprisingly common, something that we certainly will see in our career. But yeah, what's the data tell, Matt?
Yeah, when I was doing a quick lit review on this, I saw some figures as high as 5% of patients exposed to heparin for more than 4 days. In my personal experience, that seems a little high. I don't think 1 out of 20 patients are getting hit that are being exposed to heparin. There's been a couple studies that have looked at this over the years. There's a New England Journal from 1995 that measured patients with both low molecular weight heparin and unfractionated heparin, looking at anywhere from 2.7%. Article in Blood in 2003 showed unfractionated heparin was associated with about 0.8%. Another one in Chest in 2007 showed low molecular weight heparin's 1.2, unfractionated heparin's 1.5. So you're looking at single digits in that setting, low single digits in that setting.
And I think this is kind of the danger zone, right? I mean, this is the frequency where it's not rare. It's not a zebra, but it's not common either. We've talked, a prior episode of the podcast, we talked about like Zorses and Hebras, things that are perceived as rare, but are actually common. And that's kind of a dangerous spot to be in, because it means that it's going to be there all the time, but you may not see it unless you look for it. And so I think it's really important to, like we were saying earlier, like convince yourself why this isn't HIT. Every time you see a drop in platelets that meets the criteria, go through the exercise of the 4T score and treat it seriously, because, as we said earlier, untreated, super bad.
Yep. Just like you said, Nick, untreated mortality up to 20% in the short term. But then I think we would be amiss if we didn't talk about some of these risk factors, specifically looking at unfractionated heparin versus low molecular weight heparin in the incidence of HIT. There was a meta-analysis that looked at 7 trials that indicated an odds ratio of 3.25 for unfractionated heparin versus low molecular weight heparin in the incidence of causing HIT. And specifically among surgical patients, we know that unfractionated heparin has higher rates of inducing HIT than low molecular weight heparin. However, it's really unclear if unfractionated heparin has higher HIT inducing capabilities in medical patients. Another meta-analysis looking at 13 studies compared unfractionated versus low molecular weight heparin in about 5,000 medical patients with VTE, and found no difference in risk of developing HIT according to the type of heparin used. Alternatively, there's an article in Blood in 2006 that looked and found that females were at higher risk. However, when they parsed it out and looked at low molecular weight versus unfractionated heparin, those females that had received unfractionated heparin were the ones that were at higher risk for developing HIT.
I mean, I think my takeaway here is kind of going back to the earlier episode that we did with you, Matt, about DVT prophylaxis. You can use either unfractionated or low molecular weight to prophylax. Um, I often think that like they're almost the same price, but it's 3 shots a day versus 1. So if somebody can get low molecular weight, why not just reduce their pain by 2/3 and give them the drug that may or may not also have benefits, like reducing the risk of HIT in some populations.
And Nick, I think just to piggyback on that, it also reminds me of our discussion of pulmonary embolism, where a lot of us will sort of like knee jerk put folks on unfractionated heparin via continuous infusion. This is maybe not the number one reason to not do that, but in my mind, this is another reason to just consider doing your one mig per kg twice a day, Q12-hour dosing with your low molecular weight heparin. It's you know very effective. I really don't think the data is there to support that it causes any kind of increased bleeding risks or has any significant impact that can't be overcome as it relates to potential interventions down the road. And here we are looking at some pretty clear data that suggests the risks of HIT are higher with unfractionated versus low molecular weight. So just another point I thought I would bring up.
Yet another reason to like low molecular weight over unfractionated heparin.
Yet another reason, yes. We spent quite a while now talking about heparin-induced thrombocytopenia. We have a couple other cases I want to get to. So if I may, I think I'll pivot us towards this 47-year-old female who has known cirrhosis, prior history of hepatic encephalopathy, and she's coming in with altered mental status, elevated white blood cell count, elevated AST and ALT in a 3-to-1 ratio, all of which is worrisome for alcoholic hepatitis in the setting of known cirrhosis. So, we go back, we see that her platelet count was 115 2 weeks ago, and now she's at around 47 without any evidence of overt bleeding. She's also noted to be anemic with a hemoglobin of 8.5. But like I said, she's got a fast exam, CT imaging that's all reassuring, and a history that's not consistent with hematemesis or melanoma or anything along those lines. Matt, if you're faced with a patient like this, what etiologies would rise to the top of your differential?
Yeah, no, great case there and great intro on that one, Sives. I think it's important to touch base again on those cirrhotics and the degree of thrombocytopenia that we're seeing in them. It's estimated that up to 3/4 of cirrhotics are believed to have some type of mild thrombocytopenia, again, 100 to 150. And then 13% have a moderate at baseline thrombocytopenia. Platelet counts residing in the 50 to 90. That's even before they're acutely ill, acutely hospitalized. When you think about cirrhosis, remember that morphology that's going on, that pathophysiology that's changing in that portal venous system, and oftentimes the increased risk for things like portal venous thrombosis, splenomegaly. They can also lead to platelet sequestration. And that doesn't even get into the concerns that when you have a cirrhotic with a new anemia and the altered mental status, there's concern that there may be a GI bleed and there as well that's potentially accelerating some type of thrombocytopenia that's occurring in that setting. But again, going back to the cirrhosis and the liver damage, whether that's through alcohol, hepatitis C, other types of viruses or toxins that we talked about, that is all driving down the production of TPO. When you're decreasing TPO, eventually you're going to result in decreased platelet production. Now, to touch base on the alcohol, there's a toxic effect of alcohol on the bone marrow. We know that, but the exact mechanism of how it occurs is not really fully understood. We know that there's some interplay that's going on that's suppressing the efficacy and the efficiency of those hematopoietic stem cells. There's also knowledge that high amounts of alcohol that are being consumed interact with membrane phospholipids on your red blood cells and potentially platelets as well, and interfere with their ability to squeeze through the spleen and through the vasculature as well. And sometimes those are being caught up in the spleen as well. But alcohol also has an ability to interfere with the utilization of folate. Now, it doesn't induce a folate deficiency per se, nor does it appear to impair folate absorption. However, we have known that serum folate levels will fall acutely after rapid alcohol intake. And this is a consequence of alcohol effects on the folate mobilization and utilization as well. And that's not even taking into account the anemia of chronic disease that a lot of these patients with cirrhosis, chronic alcohol intake, are also suffering from as well, leading to altered iron absorption, altered iron metabolism. They have high ferritin states, low TSATs, which really drive down their ability to utilize that iron in the production of red blood cells within their bone marrow as well. Again, going back to that level of cirrhosis that's going on, that portal venous system hypertension that's going on sometimes as well. These patients can have things like esophageal varices, portal gastropathy. They're high risk for bleeding as well. So it's not just the alcohol that's suppressing the bone marrow efficacy, and it's not just the alcohol that's suppressing the TPO production and leading to cirrhosis. It's also, is there bleeding that's going on in this patient as well, but also metabolism in terms of nutritional deficiencies, specifically folate, and then oftentimes iron as well. These patients are having these chronic bleeds.
A perfect storm of causes.
Yeah, totally, Nick. Perfect storm of causes. Matt, I mean, I think you masterfully underlined the complexity that is cirrhosis, as just in the context of thrombocytopenia, let alone all the other issues that we have when we take care of the patient suffering from cirrhosis. I'm reminded of I want to say it was in the mid 2000s. I need to see if I can find this. Maybe the mid 2010s, but there was a great New England Journal of Medicine article discussing specifically the coagulopathy of cirrhosis, which I think is what we really, I mean, that's what I harp on when I teach my residents is a lot of times we see that platelet count, it's low, and we see that INR, and we're like, oh yeah, they've got high INR, their platelet count's low, they're inclined to bleed, and it's like, well, not so fast. It's a lot more complicated than that. There is a lot of evidence to suggest that these folks are just as prone to clotting as they are to bleeding, and really, it is appropriate, I think, to look at this as more of a coagulopathy of cirrhosis rather than a bleeding diathesis. Is that kind of a reasonable way to approach it, Matt?
No, I agree exactly with what you just said, Cyrus. These people with cirrhosis, they have overt hemostatic abnormalities, like we've talked about before. They're both a little bleedy, and they're both a little clotty as well. That's why you see these patients sometimes develop portal venous thrombosis despite platelets being, in the 60s or 70s. They have something going on in terms that's probably alternating that endothelium or some type of inflammatory physiologic process that's leading or accelerating the chance for clot formation, whether that's due to, a direct endothelial abnormality or some type of vascular compression secondary to that cirrhotic morphology that's overlying that vasculature. Just like you were talking about earlier with that TEG, does this patient need platelets? Does this patient need, cryoprecipitate or coagulation factors? It's sometimes difficult to ascertain that just based off of that, that PT, that PTT, and that INR, or that patient with cirrhosis, because a lot of times we know that synthetic function of the liver is compromised. Again, going back, the liver produces fibrinogen, factor 1, thrombin, factor 2, factors 5, 7, 9, 10, 11. All of those can be, compromised in the setting of cirrhosis. If the patient has chronic alcohol use as well, oftentimes there's vitamin deficiencies that can be driving that as well, specifically vitamin K, which leads to the production of factors 2, 7, 9, and 10. And so if you have both of those going on at the same time, it can really suppress that synthetic function of that patient who's got cirrhosis. But again, they may have an underlying physiologic process that's also increasing their ability to clot in the setting of that cirrhosis.
Perfect. Yeah. So my takeaway is this is incredibly complicated, and there's definitely reason to be mindful and thorough when evaluating these patients and trying to make the right decision in terms of both what's the most likely diagnosis and then what's also the most appropriate therapy, and probably a case where your clinical exam and your investigations are going to be particularly helpful in determining where is that person leaning in terms of their coagulopathy and then intervening as such. Nick, I think you had a point you wanted to make in regards to the INR.
Just to add to that point, a great point. I think, the INR is one of the most abused and misused numbers in the history of medicine, right? I mean, it's a test that was developed to sort of tell us how effectively warfarin was working, but we sort of often misapply it in a lot of settings, and this is one of them. Not to say that INR doesn't have value in people with liver disease. It can be an important marker of disease severity. It goes into your MELD score. It goes into other prognostic scores. But just remember that it's not the only marker. And if you take away anything from all the clotting factors that Matt just rattled off from memory, this is complicated, and people are bleedy and clotty. And one number is not going to tell you which they are. You need a more nuanced assessment of coagulation.
So Nick, I think probably a good time to move on to our last case, because we've covered just a ton of material, and we have some potpourri topics as well. Do you want to see if you can throw Matt a little curveball here?
Yeah, okay. Here's curveball. Now that you know it's a curveball, you'll know how to swing at it. That's all right. So this is a 28-year-old woman with 3 days of diarrhea that's both mucoid and bloody, who comes into the ICU, comes into the hospital with a fever to 102, malaise. She's encephalopathic. She's quickly intubated for airway protection. And the physician who intubated her notes that just the act of putting the blade in her mouth, seems to cause spontaneous bleeding. They get a set of labs, and the lab calls with a critical result. Her platelets are 24. I'll add that renal function is normal, but her LDH is highly elevated. How do you work this up? What are you thinking? Kind of walk us through next steps.
Yeah. So to recap with this patient, Nick, we've got a young female, metachesia, fevers, some type of coagulation abnormality in the setting of airway bleeding, thrombocytopenia, and an LDH. And when I see an LDH that's elevated like that and a thrombocytopenia, I'm first starting to think that maybe there's something sinister going on that's really starting to drive that high LDH and thrombocytopenia. And I'm concerned for some type of coagulopathy, potentially hemolytic anemia. I'm concerned, does this patient have acute leukemia? And so the first thing that I'm starting to do when I work up and see those types of physical exam findings and those initial labs is I'm doing what I like to call is dick dat smear, or get that smear. I get a DIC panel. That DIC panel is going to give me my coagulation factors. It's also going to give me a fibrinogen. I'm also getting a direct Coombs test. I'm trying to figure out, is this some type of hemolytic anemia that's going on? And then I'm getting a smear as well. When I look at that smear, I'm going to be able to see, okay, is there a bunch of schistocytes that are floating around? Am I worried for something like DIC or a TMA or some other type of phenomena that's lysing red blood cells intravascularly that's driving this? Alternatively, is there leukemia? This patient's coming in with a thrombocytopenia. They have a high LDH. They're mucosal bleeding. That's not an uncommon presentation for somebody who has an acute leukemia. And so that's one of the first things I'm starting to do. As we go down and we're looking at some of these tests that come back, and I'll just kind of walk through what I think may be going on with this patient. Say you get that Coombs test back and it's negative. Okay, so there's not an autoantibody there that's leading to some type of hemolytic anemia. But notice we have an increased LDH. In that same setting, this patient may have something like an increased bilirubin, low haptoglobin. That really clues me in to think, okay, is there an immune-independent hemolysis going on in here? Is there something intravascularly that's lysing red blood cells or chewing up platelets that are leading to this patient's manifestation?
Great. Yeah, you're correctly anticipating what comes next. So let's say that now you get a stat call from the lab. They're saying they see schistocytes on the smear, many schistocytes, not just a few. How does that change your thinking? What comes next?
So when I see many schistocytes, the first thing I want to determine is this DIC, okay, disseminated intravascular coagulation. And when I'm going to make that determination, it's going to be based off of that coagulation cascade, which is going to be measured by your PT, PTT, and INR.
So let's just say that the DIC panel comes back negative. You don't have depletion of all these factors. So you have schistocytes without DIC.
Okay, so we've got some type of hemolysis going on, and we've got schistocytes independent of a coagulation phenomenon that's going on. So to kind of recap, we have schistocytes on the smear. We also have thrombocytopenia. Okay, those two findings are associated with a phenomenon that's called MAHA, or microangiopathic hemolytic anemia. And when you see the schistocytes on the smear and you see thrombocytopenia, that's going to clue you in specifically to a MAHA, non-immune mediated hemolysis, specifically in this patient. Again, something that's going on that's shearing those red blood cells, and that's also utilizing those platelets.
Excellent. And you have a mnemonic for everything, it seems. What do you have a way to think about these, like to think about what to do next?
Yeah, so what I like to do is, as soon as I get into this space where I found that there's a MAHA going on, I try to think of things that I can do to reverse it or treat an underlying cause. And those underlying causes, I like to think of, okay, what am I doing in terms of dropping dimes to figure out what's going on that's causing this? So that's DIC, I, infection, M, malignancy, E, eclampsia, S, severe hypertension, S, severe rheumatologic diseases, because all of these systemic disorders require therapy directed at that underlying disorder, whether that's antibiotics for sepsis, whether that's delivery of the baby for severe eclampsia, whether that's, some type of immunosuppression for that severe rheumatologic disease, rather than specific therapy for that TMA itself.
So treat the underlying cause.
Yes. And again, we always say this for patients that have, severe DIC. A lot of times that's triggered by an infection. But that's the basis in treatment for these patients.
So let's say Matt, okay, so you've dropped your dimes and you're not really coming up with anything in terms of a secondary disorder. So when do you start to look for, or would you start looking for a primary cause at this point? And if so, what would be on your differential for that?
No, absolutely. And so if there's no obvious etiologies that have been identified after you've been dropping dimes, attempt to ID a primary thrombotic microangiopathy that's going to potentially require a medication or some type of intervention directed at that thrombotic microangiopathy. We're talking things like TTP, thrombotic thrombocytopenic purpura, Shiga toxin-mediated hemolytic uremic syndromes, drug-induced thrombotic microangiopathies, complement-mediated thrombotic microangiopathies. Some of these rare things that aren't necessarily thought of right away. The patient may manifest or the patient may present, and you're thinking one thing's going on, but these are more kind of, you're really getting down the well in terms of what some of the classical hematologists really get excited about. These syndromes require urgent targeted treatments, typically directed at that TMA or removing things that are offending and causing that TMA. And so this is really where the importance of a history, physical exam, really understanding who this patient is, where they're coming from, and what's going on is really going to help you. For example, HUS, there's a higher likelihood in children. There's also higher likelihoods of drug-induced thrombotic microangiopathies in populations of patients who are on immunosuppressive medications, patients that have kidney transplants, patients that have received hematopoietic stem cell transplants. Make sure you're asking about things like animal exposures in terms of HUS causing that. And so that's really, go ahead.
So I was going to say, so at this point, we're really down the well, as you said. Like, we're worried about rare, life-threatening causes. This is where we need a specialist involved to help us. But while we're like trying to get you to call us back in the middle of the night, what labs can we send to help out?
Yeah, and so me personally, my own practice pattern, when I see schistocytes on a smear, when I see thrombocytopenia, when I've got MAHA and I've got a normal coagulation factor, I'm sending off an Adams TS13 right away. Adams TS13 is an enzyme that cleaves von Willebrand factor multimers in the vasculature, and its deficiency promotes formation of platelet microthrombi within the vessels. Patients can have very mild kidney injury, usually not very severe, but this manifests in a phenomenon that's called TTP, thrombotic thrombocytopenic purpura. This is a true hematologic emergency that typically requires intervention in the form of plasma exchange. What happens is that deficiency is brought on by an antibody targeting and removing or blocking Adams TS13 from cleaving those von Willebrand multimers within the vasculature. So as these red blood cells and these platelets are coming down through the vasculature, the platelets adhere to that von Willebrand factor multimer, and as the red blood cells come down, they become sheared and lysed. That's when you get these schistocytes, you get this LDH spilling out all over the place, you get all this free hemoglobin in the intravascular space, which drives down your haptoglobin. And this is a true emergency. They can get thrombotic complications and they can die from it. They get very severely anemic very quickly. And
just as a quick point here, I think people often get led astray by what they're taught in med school here because they go looking for something called the TTP pentad. They talk about this sort of cluster of symptoms that define TTP. What are your thoughts on that, Matt?
Yeah, so that TTP pentad, that's fevers, anemia, thrombocytopenia, renal insufficiency, and neurologic dysfunction. You only see neurologic dysfunction in up to a third of these patients. Fevers are actually not even that common. And renal failure, renal insufficiency is not severe. In fact, and one of the things that we're going to use when we're talking about TTP is a score that's called a plasmic score. And if you have severe kidney dysfunction, if your creatinine's above 2 from a plasmic score, it rules down the chance that there's actually TTP. The other things you look at in the plasmic score, it's also if the platelets are above 30, if there's hemolysis in the setting of an elevated indirect bilirubin and a low haptoglobin, if the patient doesn't have a history of a solid organ transplant or stem cell transplant. Again, those patients often are on immunosuppressive medications that are sometimes associated with inducing a thrombotic microangiopathy. One I've seen before is tacrolimus. Is the MCV low? Do they not have a severe B12 deficiency, which can mimic TTP as well? Is their INR below 1.5? Remember, this patient does not have DIC. There's no consumption of their coagulation factors that's going on. It's merely platelets that are sticking to that big von Willebrand factor multimer, and as the red blood cells come through, it's lysing. If these patients have an intermediate risk score, which is 5, it's a good idea to send off that Adams TS13 and get them started on plasma exchange in the meantime. Certainly if they have a higher score, 6 and above, that's a high risk for TTP. It's very important to get them started on plasma exchange if there is a high concern for TTP, because that Adams TS13 is sent off to reference labs. There's only a couple in the country that actually run them. And so it can take 1 to 2 weeks to actually get it back. And in the meantime, that mortality for untreated TTP is very high. I've seen it reported above 90% if untreated within 2 to 3 weeks. So you don't really want to be waiting around. You want to get above the curve and do a plasma exchange, take that patient's plasma out of their body so as to remove that antibody that's targeting and destroying the Adams TS13 and give them new plasma with Adams TS13 in it as well, so it can cleave those big, large von Willebrand multimers that are floating around in that vasculature causing all this dysfunction. Ultimately, if that Adams TS13 level comes back and it's low, 10% and lower being a cutoff, that gives you that diagnostic criteria for meeting TTP.
And so Matt, just to clarify, because I know it's a little confusing, the Adam TS13 assay that we're sending off, it's not giving us an amount, but it's actually assessing the activity of that Adam TS13. Is that correct?
Absolutely.
Okay, great.
And I think just a hot sort of a meta point I'd like to make here, which is that, often in medical education, we talk about like triads and pentads that are diagnostic of disease, but these are things that were usually described like 100 or more years ago. And disease often presents earlier and more subtly now. And you don't want to wait until the whole pentad is present. You want to diagnose it sooner. So don't wait for, every manifestation to be present to think about TTP. Think about it sooner. Send the Adam TS13 off sooner. And then use a risk score, the plasmic score, to actually objectively weigh the risk. And you'll use that as part of your decision to treat or not. This is a great transition to talking about treatment. So you mentioned some of the treatments, Matt. You mentioned plasma exchange. What else?
So in addition to plasma exchange, removing that antibody out of the patient's serum and giving them a replenishment of Adams TS13, you're also wanting to suppress the cause for why that antibody is being produced. So you're going to give them a high dose steroids. You're looking at anywhere from 1 mg per kg per day of prednisone up to even 1 gram of solumedrol burst up to 3 days, followed by a taper. Oftentimes what a lot of hematologists will do is once that Adams TS13 comes back and it's low, then they're adding on rituximab, CD20 targeted antibody, which is targeted at B cells, which eventually become plasma cells that produce antibodies. So you're trying to suppress not only from steroids, but also in a molecularly targeted monoclonal antibody, to suppress the production of that antibody targeting that Adams TS13.
And as a quick side note here, so plasma exchange, you're going to need a big hunkin' line to do that, right? And this often comes up. This person's platelets are low. Can you safely put it in? And I think, one thing that, we talked about on an earlier episode of the show, we talked about a randomized trial where they randomized people to platelets before or not. And the conclusion was not. That do your line in a compressible place. Have somebody experienced do your line. That's the right way to do it. I think another point to make here is that treating the underlying cause is much more important than the procedural risks, right? Like if this person truly has TTP, like you want to start treatment soon. You don't want to hem and haw about getting their platelets above, some magic number that you think will make it slightly safer. Do you have any thoughts to add to that, Matt?
No, I agree 100% with what you just said. This is not something to sit around. This is certainly not something to hem and haw and put a line on. Get that line in them quickly and try to get that plasma exchange going when the concern for TTP is high, because that TTP is going to kill them sooner rather than later. You can always give them more platelets down the road if they start to ooze out, but I wouldn't set around if TTP is on the differential.
And correct me if I'm wrong too. Like I think in this case, if your platelet transfusion is really not going to help your cause, so it could add fuel to the fire, right?
Absolutely. Again, if you have very large intravascular volume of von Willebrand factor that's floating around, as soon as it comes in, it's going to be those platelets. As soon as they're being transfused, they're going to bind up to those von Willebrand factors again. So you're not really mitigating the underlying cause for what's going on. You got to get that antibody out of there. You got to get those large von Willebrand multimers out of there. You got to replace them with appropriate levels of Adams TS13. Just like you said, Cyrus, it's almost adding a little bit of fuel to the fire in terms of that thrombotic potential that's going on with all those platelets that are adhering to those big von Willebrand multimers floating around.
Excellent. So we're treating it, we're thinking about it early. We're using a structured tool to assess the risk. We're sending the lab. We're starting treatment early if the risk is high. Any other therapies we can throw at this other than steroids, Plex, and rituximab?
Yeah, another monoclonal antibody that's known as caplacizumab that binds to von Willebrand factor and actually blocks its ability to interact with the platelets and the glycoproteins. It's definitely not standardized when to use it. Some hematologists will use it up early, especially in the setting of neurologic abnormalities or strokes or things like that, to really try to mitigate the effect of that von Willebrand multimer as much as they can. Certainly, there's a 2020 International Society on Thrombosis and Hemostasis guideline that makes a conditional recommendation for using it in the setting of a critical illness, neurologic findings, high troponin. I would use it up front if you can't access Plex. Granted, if you're not able to access Plex, you might not be able to access caplacizumab, or if the patient refuses blood products outright. When you're doing plasma exchange, you're giving them a blood product. You're giving them plasma from somebody else. And some patients are not comfortable receiving somebody else's plasma for various reasons. And that's the setting which I would also use caplacizumab, steroids. I'd probably give them rituximab up front as well. And in terms of how long are you continuing to do this Plex for after you've started, typically until that platelet count increases greater than 150 for 2 days, or it increases and then it starts to plateau for 3 days, at least to an appropriate level, typically above 100, low 90s, something in that range. I would consider that a response and then start to taper those steroids.
Perfect. So just to make sure that I'm clear on this, so you're giving these folks often a combination of therapies, and a traditional one would be steroids plus plasma exchange.
Yes, steroids, plasma exchange, those are the ones you're going to give to them first, especially if it's a really high concern. You're not wrong giving them a dose of rituximab as well while you're waiting that Adams TS13 to come back. But ultimately, if they're critically ill, if they've got neurologic derangements, I'm probably reaching for caplacizumab at that time as well, and then certainly introducing caplacizumab if there's a contraindication for Plex itself.
Awesome, Matt. Thank you. That's a incredible discussion on TTP. Tons of high yield pearls there. Now, before we close out this case, though, I did want to talk about maybe some other potential diseases that would be sort of high on your differential, like hemolytic uremic syndrome and anything else you might want to bring up. What are you thinking?
No, and that's a good point, especially with this, kind of this younger patient. She had diarrhea, it became bloody. She's got a MAHA and thrombocytopenia. One of the things that should always be on the differential is this a shigatoxin-mediated HUS. Oftentimes, these patients will have some type of exposure, whether that's eating undercooked meat, some type of farm animal exposure, eating unclean vegetables, being around unclean water. Typically, this occurs several days before the onset of the symptoms due to the Shigella. Some serotypes of E. coli, specifically 0157H7, these can result in damage to the kidneys and epithelial cells, vascular endothelial cells, resulting in this MAHA and this thrombocytopenia. These patients will commonly present with abdominal pain, nausea, vomiting, diarrhea that becomes overtly bloody. In adults, there may be concern for ischemic colitis up front. They oftentimes can have kidney injury as well. The MAHA and the thrombocytopenia seem like they occur several days after the onset of the abdominal pain and the diarrhea, when the initial symptoms actually begin to resolve. And so it's very important to test that stool sample for shigatoxin-producing organisms or Shigella itself. In terms of treatment for that, antibiotics are really only used for sometimes these extra-renal manifestations, these extra shigatoxin-inducing sequelae like pneumonia. Anti-diarrheal agents may not even really be needed because the diarrhea may be resolved by the time this patient manifests with this TMA. But at the end of the day, you're looking at supportive care, transfuse these patients as needed, and dialysis as well.
Real quick, I just want to make sure I'm clear on the time course. So if someone is, in a classic case of Shiga toxin mediated hemolytic uremic syndrome, what would you expect the time course to be?
Good question. Typically, you're looking at abdominal pain, diarrhea. That's occurring several days before they manifest the hematologic abnormalities, before the MAHA, before the thrombocytopenia.
Got it.
The diarrhea may fully resolve before this MAHA has fully presented itself.
I see. So really, I think really important point there gets back to the history, right? I mean, if someone's coming in and they had diarrhea for 2 days, it was bad, it resolved, and they're feeling better from that standpoint, and now they're coming in a few days after resolution, they may not immediately volunteer that element of the history. And so I think, it underlines the importance of a good review of systems, that sort of thing, especially if something like STHUS is on your differential.
And conversely, if somebody comes in with diarrhea and then the diarrhea gets better, but then they're thrombocytopenic, thinking about that, you may have caught them at the early stage and now you're seeing the MAHA developing later. So yeah, I think this is like a disease that has kind of protein manifestations, and it's like easy to get fooled if you don't look at the whole thing in context and watch for that evolution.
Absolutely.
Excellent. There's one other thing I think you wanted to bring up, Matt.
Yeah, the other one that's pretty atypical, but something else that should be on your differential in the setting of a MAHA, thrombocytopenia, normal coagulation factors, especially if that Adams TS13 comes back and that's above 10%, or if you don't see any Shiga toxin floating around, or you haven't caught any Shiga toxin or E. coli in cultures, is complement mediated thrombotic microangiopathy, especially in the setting of microangiopathic hemolytic anemia, thrombocytopenia with normal coags, and you've ruled out TTP. You haven't found any sources that make you think that this is an HUS. Ultimately, with a complement-mediated TMA, commonly there's an autoantibody against complement factor H, which causes uncontrolled activation of complement on cellular membranes, including vascular endothelial and kidney cells. So these patients will manifest with oftentimes severely depressed kidney function, sometimes requiring CRRT or dialysis in the meantime. And we have a medication that's a terminal complement blockade called eculizumab. This may prevent end-stage kidney disease or even reverse the acute kidney injury that's going on. And its empiric use it's appropriate in patients with rapidly advancing kidney failure if they're meeting some of those criteria we just discussed.
Excellent. Yeah, I think that's a good one. That's a good one to remember. I feel like eculizumab comes up in some other contexts too that maybe we can talk about in a future episode. I just want to summarize kind of what we covered in this case. I think it's really important for our listeners. First off, when we see low platelets in the setting of multisystem disease, especially, remember to send DIC, DAT, smear, DIC panel, DAT or Coombs test, and then a smear. When we see the pattern of thrombocytopenia, hemolytic anemia, and organ failure, we need to think about MAHAs, microangiopathic hemolytic anemias, and remember that these are medical emergencies.
And also, do not forget to drop some dimes if you're thinking the patient's got a MAHA.
Drop some dimes for your differential there. And remember that prompt diagnosis is essential. So if you see a potential MAHA, send an Adams TS13, get your neighborhood hematologist involved so they can do whatever it is they do, prescribe Netfliximab or rentaltuximab or boozcruzumab or whatever the latest monoclonal is.
Oh, I could go on a booze cruise right now. Right. So, Nick, great summary. Again, we got some great mnemonics, dic, dat, smear, dropping dimes. So hopefully our audience will appreciate that and they'll remember that going forward. As we close things out, I did want to do a little thrombocytopenia potpourri. I know this is a longer episode, and I think for good reasons. There's a lot to really dig into here. As a throwback to our episode with you, Matt, on DVT prophylaxis, remind me, what's that magic number for which we should hold DVT prophylaxis as far as platelets go?
No, that's a good question, Cyrus. There's no definitive hard and fast hold DVT prophylaxis at this certain threshold level. It's really kind of more nuanced in assessing that patient's proclivity to clot. Look at the clinical picture and determine, is this patient, going to be bedridden for a prolonged period of time? Maybe they've got some type of lower extremity intervention. And they also maybe have something else going on already, like a myelodysplastic syndrome, and they have already got low platelets. all those things may increase their risk for developing thrombotic complications. And so really assessing, the risk versus benefit, of giving that patient anticoagulation. A lot of places you'll see them hold DVT prophylaxis for platelets below 50, but again, really make sure you're taking into account the patient's prothrombotic underlying attributes that may increase their risk for developing blood clots, even with platelet counts below 50.
Yeah. And I think the classic case I think about, again, I know we keep coming back to this underlying pathology, is your patient with cirrhosis. So like step back and realize that the platelet count is just a small element of where they actually are on that continuum. And so I will often continue some form of DVT prophylaxis in folks that are platelet counts of 30, so long as I've got close eyes on them, they're in the ICU, let's say, and especially if they've demonstrated a proclivity towards clotting.
All right, on to our next potpourri topic. Is there utility in running platelets during a procedure in somebody who's got severe thrombocytopenia?
That's a good question as well, and it's something we run to as well often. It's really dependent on the procedure. If that procedure can't wait, and if the degree of thrombocytopenia is prohibitive to doing the procedure, some interventionalists are going to want to wait until those platelets are up. But again, going back to if they're going through a neurosurgery, you want those platelets above 100. If they've got some type of major surgery or therapeutic endoscopies, a lot of times they're going to want platelets above 50. Bronchs, you guys usually look at 20s to 30s in that type of space. Yeah, and then
pretty.
If you're doing a lavage, yeah.
And then, bone marrows, some of the things I was seeing in the literature was indicating, be cautious below 20. Some of these patients are coming in with acute myeloid leukemia or, severe ITP, and you're working them up, and their platelet counts may be in the single digits. You're not really going to wait and give them a transfusion, wait, the next day or several hours later to reassess to see, okay, is it above 30 now or 20? Can I repeat this bone marrow biopsy? I've done bone marrow biopsies on patients with their, platelets in the single teens, if not lower. Ran platelets at the same time just because I'm trying to get them back above that 10 threshold. But, if the procedure can't wait and they're going to die or they're going to have a significant morbidity without it, I caution against waiting. It's never wrong just to, infuse the platelets at the same time.
So just to make sure that because this is like some hogwash myth or what have you that I've come across. There's nothing really like magical about running those platelets while you are doing the procedure. It's more along the lines of like you're in a situation where the procedure needs to get done quickly, and so you're going to kind of administer the platelets alongside the procedure rather than doing it in a stepwise fashion.
Yeah, absolutely. Those platelets aren't like more sticky when they're infusing at the real time while the procedure is going on. I think that's probably, again, I think a lot of medicine, we have this, this ignorome where we like feed each other these like pearls that maybe aren't even
drinking out of the faucet as opposed to drinking out of a cup. It tastes better, right?
Yeah, absolutely. Yeah, I've heard that as well. Sorry, and I kind of have that same type of perception about it.
Perfect. And then another couple questions I think we have for you, Matt. So specifically in the setting of blood cancers, of course, we see a lot of these folks in the ICU as well. And I guess my question really is they're like always thrombocytopenic. And so you're going to like run out of all your platelets if you're just always transfusing them. Can you remind us with those folks in particular, how you approach transfusion thresholds?
Yeah, so anytime platelets are below 10, transfuse them. Anytime they're below 20 and fevering, transfuse them. Anytime below 50 and evidence of bleeding, transfuse them. Platelets.
Perfect. Very
Great.
easy, straightforward.
Okay, quick question, I hope. When do you use those fancy platelet stimulating agents?
So those fancy platelet stimulating agents, they take on the role of thrombopoietin. They bind to those thrombopoietin receptors and induce megakaryocytes to release platelets and further differentiate platelet production. So those ones are like eltrombopag, avatrombopag, ramiplostim. You're using these ones in the setting of refractory ITP that's not responding, or maybe they're intolerant to steroids or some of these other B-cell targeting agents like rituximab. You're oftentimes using them as well in the setting of aplastic anemias in conjunction with immunosuppressive therapies or chronic hepatitis C-associated thrombocytopenia. Ramiplostim, interestingly enough, and I haven't had the chance to utilize it yet, but has a role in the setting of hematopoietic syndrome, secondary acute radiation syndrome. Side effects for these medications, venous thromboembolism. Sometimes those platelets can start to go up so quickly that they actually develop blood clots and PEs, cataracts, and they can be hepatotoxic as well.
Nice. So it's basically like Radaway from Fallout. Very cool.
Exactly. L Thrombopag is known as the Thrombopag in the United States, by the way.
Yes, yes. And I was going to say, Matt, I probably, or I may never use any of these. I may never use any of these drugs, but the speed with which you rattled off those names and the number of consonants that's what I'll remember for the rest of my life.
Thank you. Thank you very much. If you blow any more smoke up my ass, it's going to start coming out of my nose.
All right, folks. So this was a magnum opus of an episode, I'll say, where we were joined by the venerable Dr. Matthew Rendo, who did an outstanding job, I think, talking about all things thrombocytopenia, whether it be, what is a platelet? How do they get formed? Why do we care about them? Talking about how we measure them, and then kind of dovetailing that with an in-depth discussion of some of the pathologies that we need to be familiar with and how we work those up, concluding with some potpourri that I think is very helpful, specifically talking about some of those fancy agents that can be used for refractory thrombocytopenia. A nice little nod to Fallout, which is great. So really, tons and tons of content here. Matt, thank you so much for your time. Because I can say with full confidence that we would have been completely lost without your expertise. So thank you, my friend.
We can't even pronounce the treatments.
Yeah, I mean, it's always great to have you on the show. You're welcome back anytime. And so with that being said, of course, we're going to try to get some good show notes for you to cover all of what we discussed. Those will be ready on the website, www.criticalcaretime.com. And while you're there, you can subscribe to our mailing list or leave a comment. The mailing list, we hope to start using that soon. That's right, perhaps in the summer. So stay tuned.
All right. And so we're at the part of the show where we like to say thanks. First, thanks so much to Matt Rendo for being our guest and teaching us all about thrombocytopenia. Thanks to our audience, especially those of you who have left us 5-star reviews and comments. We read them. We really appreciate your kind words, your suggestions. We actually are working on episodes based on your suggestions. Hope you liked the show. If you did, be sure to subscribe, give us a like. It helps other people find the show. It helps, expand our audience, which means the world to us. We'd love to hear from you. So you can tweet at us at Crit Care Time, or individually at Nick M. Mark or at Askins_Razor. Be sure to follow Matt at RendOncology. And be sure to check out our YouTube channel, Instagram, Threads. We're on all the things.
Awesome, Nick. And of course, we also would be remiss not to thank our sponsor, C-Star Medical, especially as we come to the conclusion of season 1. We are fortunate and grateful that this episode and all the episodes of this very season of Critical Care Time have been sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more.
We'd also like to thank all the people who helped make this podcast possible, specifically our production team over at PodPaste, who probably have a lot of editing ahead of them after recording this one. And last but certainly not least, Kurt Belknap for our awesome theme music, which you're hearing now. Disclaimers time. So this podcast and all related media, including the graphics and videos, are property of Critical Care Time. Please share it, but give us credit when you do.
And of course, the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only. It should not be used in lieu of seeking medical advice.
Get a real hematologist. Don't listen to us.
Yeah, no, we don't know what
Come on.
We don't know what we're talking about. That's why we had to call Matt on. So with that being said, thanks for listening. I am once again, and hopefully will always be, Dr. Cyrus Askin.
And I'm Nick Mark. See you all next time.